And what is diabetes mellitus? What are the different types of diabetes? On that also they used to ask the question frequently. So first of all, what do you mean by diabetes? So diabetes in the broad sense you can say presence of sugar in the blood, presence of sugar in the blood and in the urine. So that is nothing but the diabetes. So diabetes is nothing but the standard definition. You can say diabetes is nothing but the chronic metabolic disorder, and it is caused by a variety of factors. It may cause by insulin deficiency, which is the main hormone responsible for the utilization of glucose in the body. It is a chronic metabolic disorder caused by various factors. First, there is a deficiency of insulin, or second, insulin resistance is there. Now, the cause of this diabetes mellitus or the etiology of this diabetes is a different. It may be a genetic origin, or it may be due to your bad eating habits. It may be due to certain drugs. It may be due to exercise. There are different causes for this diabetes. So most of the time, it is caused by bad eating habits. Okay, bad eating habits. Then alcohol, etc., etc., drinking alcohol, etc. So again, it is a chronic metabolic disorder caused by different factors like deficiency of insulin. There will be either two factors. There will be either complete deficiency of insulin or inadequate production of insulin, or there is insulin resistance due to bad habits, due to genetic origin, and due to some drugs. Okay. Now this condition is characterized by these three. Okay, this condition is characterized by increased blood glucose level or increased sugar level in the blood. So that is nothing but the hyperglycemia. Okay, then because of that increased sugar in the blood, that sugar is not utilized for the production of energy. That sugar is not being utilized for the production of ATP. So that sugar is being excreted in urine. So presence of sugar in the urine known as a glycosuria. So hyperglycemia means increase the blood sugar level. Glycosuria means presence of sugar in the urine. Okay. So hyperlipidemia due to this lipids, they are broken down. Lipids are broken down and free fatty acid levels in the blood they increases. That is nothing but the hyperlipidemia. So obviously because of the deficiency in the utilization of glucose, so glucose will increase in the body. That is nothing but the hyperglycemia. That glucose is being excreted from the urine known as a glycosuria. And as there is no glucose, yes, there is a glucose, but it is not utilized. So more production of glucose will be there. That is nothing but the gluconeogenesis, and that is from your fats, amino acids, etc. So that is nothing but that will increase the fatty acids and triglycerides in the blood. So hyperlipidemia. So these are the three symptoms, okay, characterized by glycosuria, hyperglycemia, glycosuria, and hypolipids. Increase the lipids in the. So now what happens? It results in the negative nitrogen balance of the body. So diabetes mellitus. So increase the sugar level in the body. That is a hyperglycemia. Because of that, there is a excretion of this sugar in the urine. That is glycosuria, and increase the lipids in the body. That is hyperlipidemia, and that result in a negative nitrogen balance because your glucose is not used for production of energy in the body, so it is being wasted. So that's why proteins are taken to make, they are utilized to produce energy. That's why negative nitrogen balance means nitrogen content in the body is decreased. Okay, so and because of that ketonuria is also there. Ketonemia means increased ketone bodies in the blood. Ketonemia means increased ketone bodies in the blood. Ketonuria means presence of ketone bodies in the urine. Okay, so normally what is blood sugar level? If fasting blood sugar level or fasting blood glucose level, if it is more than 126 milligram per deciliter, fasting means without taking any food. So in fasting, if fasting blood glucose level of an individual is more than 126 milligram per deciliter, or postprandial means after meal, 3 hours after meals. Okay, 3 hours after taking meals. So if postprandial blood glucose level is more than 200 milligram per deciliter, that means you are suffering from diabetes. So diabetes mellitus is diagnosed. There are different types of diabetes. Now we'll see the types of diabetes. There are different types of diabetes: type 1 diabetes, type 2 diabetes, type 3, type 4. So they may ask you a question on this. What is type 1 diabetes? What is type 2? What is type 3? Or they may ask you question like match the following types of diabetes with their synonyms or with their. So first one is nothing but the type 1 diabetes mellitus. Type 1 diabetes, okay, diabetes mellitus. So it is known as a juvenile onset diabetes. Juvenile onset diabetes. That means this kind of diabetes occurs in the children's and young adults. So juvenile onset diabetes mellitus is nothing but the insulin dependent diabetes mellitus. So it is a insulin dependent diabetes mellitus. Type 1 or juvenile or IDDM. These three are the synonyms for type 1. Type 1 diabetes mellitus or juvenile diabetes or insulin dependent diabetes mellitus, that is IDDM. So in this case, as the name indicates, insulin dependent diabetes mellitus means this patient is dependent on insulin for survival. In the patient of IDDM, there is a destruction of pancreatic beta cells. So you know that your pancreas has a different two functions, exocrine function as well as endocrine function. So exocrine function means pancreas will produce digestive enzymes and that will be secreted in the duodenum, that we will see in the digestive system. Okay, so that function of pancreas is known as a exocrine function. Now what is endocrine function? So pancreas also have some specialized cells, okay, which secretes hormone. For example, islets of Langerhans. So islets of Langerhans of the cell, these are the particularly or specialized cells in the pancreas. They used to secrete hormones. Okay, so these cells also will have different. These cells also will have the pancreatic islets will also have different subtypes. Type, okay. So A cell, B cell, alpha cell, beta cell, delta cell, etc. These alpha cells secrete glucagon. Remember, alpha cells of pancreas will secrete glucagon. Then beta cells of pancreas will secrete insulin. Then delta cells of pancreas will secrete somatostatin. Then there is one more cell known as a PP cell or pancreatic polypeptide cell. They will secrete one another hormone known as a pancreatic polypeptide. There are different kind of pancreatic function, exocrine function as well as endocrine function. If there is a deficiency of this insulin secreted by beta cells of Langerhans, that result in the diabetes. So type 1 diabetes is nothing but the juvenile onset of diabetes or insulin dependent diabetes mellitus. Okay, and in this type of diabetes occurs in the young young children's and young adults. So it is known as juvenile onset diabetes because that age is nothing but the juvenile onset of diabetes. So in this case, the patient has to rely on insulin for lifetime because there is a destruction of beta cells of Langerhans in the pancreas, and because of that, there is no production of insulin or very less production of insulin or insufficient production of insulin. That's why the patient has to take insulin from external source. Okay, so this patient they takes lifetime insulin. Now type 2 diabetes is nothing but the maturity onset diabetes. Type 2 is nothing but the maturity onset diabetes. It is also known as non-insulin dependent diabetes mellitus. NIDM. NIDDM. So NIDDM. IDDM and NIDDM. IDDM मतलब insulin dependent diabetes mellitus. NIDDM मतलब non-insulin dependent diabetes mellitus. So as the name indicate here, non-insulin dependent diabetes mellitus. So this kind of diabetes is not dependent on insulin. Means the patient who are suffering from this type 2 diabetes, they are not dependent on the insulin. Means there is a insulin in their body. So it may be inadequate, it may be less, it may be inadequate, or the sensitivity of the cells to a insulin that is decreased. Okay, so this is non-insulin dependent diabetes mellitus. So there is a okay. So in this patient, in this type of patient, those patients suffering from type 2 diabetes, then they may not need any insulin. So this patient does not need any insulin. But in case of emergency cases, in case of few exceptional cases, so you may need insulin in these also. But it is a non-insulin dependent diabetes mellitus. Now what happens in this case? Abnormality of glucose receptor to the beta cells. So okay, so most of the time here what happens, insulin is there but there is a resistance, abnormality of glucose receptor, that is on a beta cell. Patient has insulin in the plasma in this case, but response to glucose concentration but insulin resistance is there. So insulin is there, but it cannot work. Okay, that is the case in type 2 diabetes. That is a non-insulin dependent diabetes mellitus. Now this kind of diabetes occurs in the mostly obese patient. Obesity. So those patients which are having obesity. So in such kind of patients, this diabetes is mostly often. This occurs in the obese patient and it is complicated by ketoacidosis, means increased in the ketone body formation and increase in the acid in the body, lactic acid and that. So increased ketoacidosis, reduced sensitivity to the insulin receptor. And because of it, the utilization of glucose is so reduced utilization of glucose. So in type 1 diabetes, known as the insulin dependent diabetes mellitus, here it is a complete destruction of beta cells of pancreas, and because of that there is a deficiency of insulin. Now in case of type 2 diabetes, known as a non-insulin dependent diabetes mellitus, there is the insulin. Whenever you will eat sugar, so insulin will be released, but that insulin and its receptor, they are not interacting. So here is the resistance of insulin. Now type 3 diabetes, in the type 3 diabetes it is known as the, it is due to the hormonal disorders. Type 3 diabetes is nothing but the due to hormonal disorders, and now it is treated by the treatment of this type 3 involves the oral hypoglycemic agents. We are going to see the classification and all that. Now type 4 diabetes mellitus. Type 4 diabetes mellitus is known as a gestational diabetes mellitus. Gestational diabetes mellitus or GDM. Now as the name indicates, gestational matlab it means this diabetes or increase in the body sugar level in the body happens in the when a lady is in a its pregnancy is pregnancy. So type 4 gestational diabetes mellitus, and it is nothing but the diabetes in the pregnancy, and it is also treated by modification of diet and insulin. So these are the four types of diabetes mellitus: type 1, type 2, type 3, type 4. Type 1 is insulin dependence, there is a requirement of insulin. Type 2 is a non-insulin dependent, means there is no need of insulin. There is insulin but resistance is there. Okay, so in case of type 1, patient needs or patient required insulin lifetime. In type 2, patient does not require insulin. Okay, so it can be treated with the oral anti-hyperglycemic drugs, or in exceptional cases you may require insulin in emergency. Now in case of type 3, it is due to hormonal imbalance or hormonal changes, so it is again treated by oral hypoglycemic drugs. Again type 4 is nothing but the diabetes in the pregnancy or gestational diabetes mellitus, again treated with the modification of diet and insulin. So remember, so type 1 and type 4 requires insulin. Okay, type 2 and type 3 will not require insulin for the treatment. Remember, type 2, in case of emergency or rare condition, you need an insulin. Now what is insulin? Insulin is nothing but the hormone secreted by beta cells of Langerhans. I have told you there are different kind of cells in the pancreas. So pancreas will have exocrine function as well as endocrine function. So whatever trypsin, chymotrypsin, amylase, so all the digestive enzyme that is secreted in the duodenum by pancreas. So those are nothing but the exocrine function, and the hormone which are secreted into directly blood. For example, insulin, glucagon, somatostatin, pancreatic polypeptide. These hormones are known as a endocrine function. So beta cells of, so there is a specialized cells in the pancreas known as the islets of Langerhans. Now islets of Langerhans will also have different kind of cells. So they will have alpha cells, beta cells, delta cells and PP cells. So alpha cell will secrete a hormone known as a glucagon, beta cell will secrete a hormone known as a insulin, then delta cell will secrete a hormone known as a somatostatin. Then again PP cell, they will secrete one hormone known as a pancreatic polypeptide. So try to remember these. Pancreas में 4 टाइप का सेल होता है आपका, अल्फा सेल, बीटा सेल, डेल्टा सेल एंड पीपी सेल. तो हर एक सेल कौन सा एंजाइम सिक्रेट करता है ये भी इंपॉर्टेंट है, उसके ऊपर भी क्वेश्चन आ सकता है. ओके, यहाँ पे मेंशन नहीं मैं लेकिन बोला. नाउ व्हाट इज द फंक्शन ऑफ इंसुलिन? इंसुलिन का फंक्शन क्या है? व्हाट इज द फंक्शन ऑफ इंसुलिन? सो इंसुलिन इंक्रीजेस द peripheral utilization of glucose and production of ATP. What is the function of glucose? Insulin. So insulin is the hormone responsible for the utilization of glucose. Okay, so glucose, you know that different, your body is made up of different cell, and every cell has its metabolic fact. Every cell will have metabolism. Okay, and every cell requires energy for survival. For example, brain is totally dependent on the glucose. Glucose is the only energy source for brain. Again, glucose is the only energy source for erythrocytes or RBC. Glucose is energy source for brain, RBCs and other cells. But other cells can utilize glucose, or they can utilize other fuel like protein and lipids for generation of glucose. Brain and RBC, they are totally dependent on the glucose for energy. Remember. Okay. Now, how this glucose enters in the cell? Glucose enters in the cell via different glucose receptors or different glucose transporters, and that is produced by this insulin. So, insulin increases the peripheral utilization of glucose. So, entry of glucose in the cell, that is guided by your insulin. For that, insulin is required. What happens if there is a insulin deficiency? So, decrease. Okay, if there is a insulin deficiency, that means so your glucose will not be utilized. So there will be increase in the glucose level of body, hyperglycemia. So what is the functions of this insulin? Increases the peripheral utilization of glucose and production of ATP. Then it decreases the synthesis of glycogen. Insulin will decrease the synthesis of glycogen in the liver and muscle. It increases the protein catabolism. It increases the gluconeogenesis. It increases the lipo. Okay. Now deficiency of insulin result in the hyperglycemia, increased the protein catabolism, then gluconeogenesis, increased lipolysis with increased plasma free fatty acids. Deficiency symptoms of your insulin. If there is deficiency of insulin, that means sugar will not be utilized, and your body will try to make another sugar from other molecules like gluconeogenesis. So ultimately, glucose level will be increased, but that glucose level, though it is increased, it is not utilized. Ultimately, hyperglycemia increase the hepatic glucose output, ketogenesis, decrease the lipogenesis. That is the symptoms of your insulin deficiency. Cell depressed your immunity, depressed cell mediated immunity. So those are the deficiency symptoms of your insulin. So now what is insulin? It was isolated by first time from the extract of pancreas. So insulin was the first time isolated from the extract of pancreas by this scientist Benting and Best. So this was again a question in exam. So remember, this Benting and Best was isolated insulin first time in 1921. Now diabetes is characterized by presence of sugar in the urine. Okay, and the patient is, you can identify diabetic patient easily by these three P's. Okay, so if patient is suffering from diabetes, so he is having polyuria, polyphagia, polydipsia. Polyuria means frequent urination. Okay? Polyuria means frequent urination. Polyphagia means increased thirst. Polydipsia means increased. These are the three P's of diabetes. You can characterize diabetes patient easily. Polyuria, polyphagia, polydipsia. Physiology of your carbohydrate metabolism. Whatever carbohydrate you are taking in a diet, you are consuming daily carbohydrate in the form of starch. In the form of starch, you are eating rotis, chapatis, and whatever. So all these consist of the starch. Starch is nothing but the polysaccharide. Okay, and you may eat sugars like disaccharide, sucrose, and all that. Okay, so carbohydrate metabolism start from mouth itself. Carbohydrate metabolism start from mouth itself. Your saliva has one enzyme known as a salivary amylase. Your saliva has one enzyme known as a salivary amylase. Okay, so it is also known as a taline. PTYLIN. So salivary amylase is also known as taline. Remember. So they may ask you question on this. For example, carbohydrate digestion start from, or they may give you option like mouth, your stomach, intestine, etc. So it start from mouth itself, because there is one enzyme known as salivary amylase or taline, which is present in the saliva. Okay. So if you eat a chapati, if you take a warm chapati and if you chew it in a mouth, so you may experience a sweet taste. That is due to the digestion of polysaccharide in the mouth itself. But this taline or the salivary amylase break down the polysaccharide into oligosaccharides, but it will not directly convert into monosaccharides. Okay, remember. Now, this salivary amylase metabolizes the sugars or polysaccharides partly, not completely. But pancreatic amylase that will break the polysaccharide into oligosaccharides or disaccharides. Now, oligosaccharides, whatever is you are getting over here. So, whatever oligosaccharides are there from polysaccharide, oligosaccharides. Poly means what? 100 plus monomeric unit. Oligo means what? 10 to 20 monomeric unit. Pancreatic amylase will break down the starch into oligosaccharide. Now this oligosaccharide, now it is present in your intestine. Now there is another enzyme in the intestine known as alpha glucosidase. Alpha glucosidase is the enzyme present in the brush borders of jejunal enterocytes. So jejunum, so that is the area of your intestine, jejunum, ileum. Okay, so jejunum in the jejunal enterocytes means jejunum intestine cells. So there is one enzyme known as alpha glucosidase. So it is present in the jejunal enterocytes. Now it breaks down oligosaccharides into monosaccharides directly. Okay, so oligosaccharides they are broken down into monosaccharides by this enzyme known as a alpha glucosidase. Remember, alpha glucosidase, and then finally monosaccharide will be absorbed in the blood. Okay, and this is one of the target for anti-diabetic drug. It is also one of the target for this alpha glucosidase is also one target for anti-diabetic drugs. Alpha glucosidase inhibitors, for example, your acarbose is there, miglitol is there, volgibose is there. So this will inhibit the alpha glucosidase and will prevent the breakdown of oligosaccharide into monosaccharide, and that's why they will decrease the sugar level. But if you are taking glucose itself, then that will not be prevented. So we'll see the next point. So utilization of glucose. So glucose is the main source of energy for brain and other tissues. I have already told you. Main brain is totally dependent on your glucose. RBCs are also totally dependent on glucose, but other tissues they can utilize glucose as well as fatty acid for production of glucose. So insulin causes the entry of glucose in the cell and makes possible its utilization at a lower blood sugar glucose level. If insulin is not there, without insulin, so glucose will not be entered into cell. Okay, when glucose is entered into cell, that glucose is taken for glycolysis, then Krebs cycle, then that pentose phosphate pathway, tricarboxylic acid pathway. So after entry of glucose in the cell via insulin, that is that glucose is taken for the metabolic reaction like glycolysis, then Krebs cycle, then pentose phosphate pathway. So insulin is very important for utilization of glucose. Remember, okay? See the glucose level chart. So normal, if you are a normal person, if you are not suffering from any kind of diabetes, your normal blood glucose level. So normal fasting blood glucose levels of individual 80 to 120 deciliter per 80 to 120 milligram per deciliter. Fasting. If you have measured your blood glucose level in the morning without taking any food, so that is a fasting blood glucose. So just ate blood glucose level. So 170 to 200 milligram per deciliter. Postprandial means 3 hours after meal. So 120 to 140 milligram deciliter. That is a normal blood glucose level of an individual. If you are potential pre-diabetic patient, what is the glucose level? In pre-diabetic fasting blood glucose level is 101 to 125 milligram per deciliter. Just it is around 190 to 230. Postprandial blood glucose level of just postprandial blood glucose level of pre-diabetic, that is 140 to 160 milligram per deciliter. Now, what is the blood glucose level for diabetic patient? So, in case of diabetic patient, the fasting blood glucose level is around 126 milligram deciliter, 126 plus milligram, 126 or one more than 126. Just it is around 220 to 300 milligram deciliter, and postprandial is around 200 plus milligram plus 200 milligram plus. So that is the glucose level chart. So that will give you idea whether you are suffering from diabetes or not. So if you check your blood glucose level, it should be in this range, 80 to 120. Fasting blood glucose level is a fasting blood glucose level of normal individual, 80 to 120 milligram per deciliter. Now we'll see the next, insulin. What is insulin? It is again a hormone secreted by beta cells of Langerhans. So it was isolated by first time in 1921 by Banting and Best from the extract of pancreas. Now this hormone was again isolated in a crystalline form by Abel in 1930. So Banting and Best first time they have isolated this hormone from pancreas in a solution form. Now in crystalline form, this Abel was isolated in 1930. So what is insulin? It is a polypeptide. Obviously, it is a polypeptide consisting 52 amino acids. This polypeptide is of having molecular weight of 600 dalton. Remember, insulin is a polypeptide of 6000 dalton molecular weight. Now it consists of two polypeptide chain A and chain B. Insulin is made up of two polypeptide chain. Chain A will have 21 amino acid and chain B will have this 30 amino acids. 30 plus 21, 51 amino acids. Okay. So insulin is a 51 amino acid containing polypeptide. Molecular weight is 6000 dalton. Okay. It has a two chains, chain A and chain B. Chain A will have 21 amino acids. Chain B will have 30 amino acids. Now these two chains are joined together by a disulfide bond or disulfide bridge. Now this disulfide bridge is very important and it is essential for its biological activity. Whatever insulin has an activity, decreasing the blood sugar level. Okay, so for that activity, this disulfide linkage in between chain A and chain B is very important. Okay? Now, whatever insulin is available nowadays, they are often from different sources like pork insulin, then beef insulin, okay, recombinant DNA insulin. So initially, it was obtained from animals and aquatic animals, for example, fish and all that. So that is known as a pork insulin. It is a different from human insulin just by one amino acid. Pork insulin is different just by one amino acid. And this beef insulin, okay, beef insulin has a three amino acid difference. So human insulin is a 51 amino acid sequence chain A, chain B, but this pork insulin will differ. It will have one amino acid different, and this beef insulin has a three amino acid different from human original insulin, but they binds to same insulin receptor and serve the function of native insulin. Now, how there is a synthesis of insulin and storage of insulin in the human body? You know that islets of Langerhans of pancreas. Okay, so they have different kind of cells: alpha cells, beta cells, delta cells, and then F cell or PP cell. Now, alpha cells of pancreatic islets will secrete glucagon. Remember glucagon. Then beta cells of pancreas will secrete insulin. Then delta cells of pancreas will secrete somatostatin. Then PP cells or F kind of cells will secrete pancreatic polypeptide. So these are the different hormones secreted by Langerhans of pancreas, islets of Langerhans of pancreas. Okay. So remember, alpha cell will secrete glucagon, beta cell will secrete insulin, delta cell will secrete somatostatin, and PP cell will secrete pancreatic polypeptide. This glucagon and insulin, they have exactly opposite role. So glucagon will increase the blood sugar level. Glucagon will increase the blood sugar level and insulin will decrease the blood sugar level. Okay. They have opposite action. Glucagon, it promotes the glycogenolysis, glycogen breakdown of glycogen. So glucagon promotes the breakdown of glycogen, which is a storage form of your glucose. So ग्लूकोज बॉडी में ग्लाइकोजन के फॉर्म में स्टोर किया जाता है, उसको ब्रेक डाउन करता है ग्लाइकोजन, ठीक है, तो ग्लूकोज बनेगा. बट इंसुलिन क्या करता है, इंसुलिन उसका यूटिलाइजेशन बढ़ा देता है एंड दे विल डिक्रीज द glucose level. So they are having opposite action. So glucagon increases the glucagon increases the glucose level of body, and insulin will decrease the glucose level. Then somatostatin is secreted by D type of cell. Pancreatic polypeptide is secreted by this PP cell. Okay. This insulin is synthesized in the beta cells of Langerhans in the form of polypeptide known as a pre-pro-insulin. So beta cells of Langerhans of pancreas will synthesize a polypeptide known as a pre-pro-insulin, and this pre-pro-insulin is converted into pro-insulin after post-transcriptional modification. The pro-insulin. This pro-insulin is having less biological activity as compared to native insulin or original insulin. Now, this proinsulin is stored in the granules of beta cells of pancreas, released upon the stimulus. So, what is the stimulus? The main stimulus to release the glucose, to release the insulin is the glucose. So, increase the glucose level in the pancreatic artery. जैसे पैंक्रियाटिक आर्टरी के यहाँ पे ग्लूकोज लेवल जैसे बढ़ता है तो वैसे ही वहां से इंसुलिन रिलीज होता है. Okay, so this insulin is synthesized inside the beta cells of Langerhans in the form of polypeptide. Okay, first it is synthesized in form of pre-pro-insulin. Then this is modified in the body to form a pro-insulin. Now this pro-insulin is stored in the granules of beta cells of Langerhans and it is released as a insulin. Okay, released as a insulin after the stimulus. Now stimulus, that is a glucose. Okay, increase the glucose level in the body will stimulate the insulin release. So it is released in a repeated pulses in the circulation. So it is released in the repeated pulses in the circulation. So storage of the insulin in the granules of beta cells, it is increased by zinc metal जो है zinc ions will increase the storage of this insulin. Secretion is regulated by chemical, then hormonal and neuronal mechanism. So this insulin secretion is regulated by three mechanisms. So that is a chemical, hormonal and neural mechanism. So beta cells have glucose sensing mechanism dependent on the entry of glucose in the cell by glucose transporters. So पैंक्रियाटिक बीटा सेल्स जो होता है उसके ऊपर एक ग्लूकोज ट्रांसपोर्टर होता है. जैसे आपके पैंक्रियाटिक आर्टरी में ग्लूकोज लेवल बढ़ गया तो वो पैंक्रिया में चला जाता है ग्लूकोज, पैंक्रिया की बीटा सेल के अंदर जाता है थ्रू ग्लूकोज ट्रांसपोर्टर्स. So glucose transporters are there on the beta cells of Langerhans, so which gives entry to the glucose inside the beta cell. जैसे ही ग्लूकोज अंदर जाता है, ठीक है, जैसे ही ग्लूकोज अंदर जाता है तो वहां से पोटेशियम जो है उसका इनसाइड द लेवल वो कम हो जाता है. तो वहां पे क्या होता है फिर डीपोलराइजेशन होता है और उसके बाद में डीपोलराइजेशन होने के बाद में जो कैल्शियम जो रिलीज होता है वो कैल्शियम एक्सोसाइटोसिस करता है पैंक्रियाटिक बीटा सेल्स का एंड से इंसुलिन रिलीज होता है. that I am going to explain you again now. So remember over here, so increase the concentration of glucose in the pancreatic artery, so there will be glucose sensing proteins known as a glucose transporters that give entry to the glucose inside the beta cells and which causes the release of insulin. Remember the half life of insulin is around 5 to 6 minutes. What is half life of insulin? 5 to 6 minutes. So that is in plasma. So insulin will remain in the plasma for 5 to 6 minutes. Now factors determining the insulin release. So what are the different factors? They causes that they decides the insulin release. First one is your glucose. So glucose is a specific and most potent stimulant for insulin release. So small increase in the glucose concentration in the pancreatic artery leads to release of insulin. Glucose stimulate the GULT2, that is nothing but the glucose transporter 2. Glucose stimulate the GULT2. It is a transporter or it is a receptor for glucose present on the beta cells of Langerhans. After that, it will get entry into beta cell and it will inhibit the ATP sensitive ion channels. Inhibition of ATP sensitive ion channel will prevent the outward movement of potassium and that causes the increase in the potassium level inside the cell and that is nothing but the hyperpolarization and because of this hyperpolarization calcium will be released. Calcium will also cause hyperpolarization and calcium will break down the granules present in the beta cell and will release the insulin. Glucose stimulate the GULT2 and inhibit the ATP sensitive potassium ion channel responsible for the depolarization of the cell and it will facilitate the release of insulin. Glucose enters in the beta cells by facilitated diffusion via glucose transporter and metabolized in the beta cell. After a series of reaction and ion exchange to the cell, when depolarization of cell membrane reaches to a threshold, it increases the calcium ion channel inside the cell, which causes the exocytosis and release of insulin from the beta cells. That's how glucose is the factor that is responsible for the release of insulin. So glucose will release the insulin, increase the concentration of glucose in the pancreatic artery is the stimulus for release of insulin. Again, there are certain other factors also. They also releases the insulin. For example, this amino acid like arginine, fatty acids, ketone bodies, ketone, then glucose, non-glucose sugars also. They also stimulate the release of insulin. Amino acid arginine like amino acid like arginine, then fatty acid ketone and non-glucose sugars, they also stimulate the release of insulin. Then hypokalemia means decrease the concentration of potassium inside the blood. Hypokalemia will obviously will inhibit the insulin release. Then gastric hormones also, they are also a player for the insulin release. So hormones like gastrin, secretin, and pancreatic enzymes, they have inhibitory. They are inhibitory. Like gastrin, secretin, pancreatic enzyme. So they inhibit the release of insulin. Gastric inhibitory polypeptide is also there one hormone that stimulate the insulin release. So gastric hormone also will have a role in the release of insulin. Gastrin, secretin, and pancreatic enzyme. Then gastric inhibitory polypeptide also stimulate the insulin release. So all these hormones will stimulate the insulin release. Other hormones like glucagon, growth hormone, then thyroxine, then adrenocorticotropic hormone, glucocorticoids, they also stimulate the insulin release. But remember over here, somatostatin will inhibit the insulin release. So these hormones like glucagon, growth hormone, okay, thyroxine, ACTH, they will stimulate the insulin release, but somatostatin will inhibit the insulin. Again, insulin release is also done by CNS, so it is also important for insulin release. So brain regulate the insulin release by different mechanisms. First is nothing but the via release of catecholamines. So brain will release catecholamines like adrenaline and all that. Hypothalamic releasing factor. So brain will regulate the insulin release by releasing the catecholamines or hypothalamic releasing factor and via ANS, via autonomic nervous system like parasympathetic stimulation and selective beta. Okay. So parasympathetic stimulation will also will also regulate the release of insulin. Particularly this beta 2 receptor stimulation, beta 2 adrenergic receptor stimulation that causes the insulin release, but stimulation of alpha 2 receptor will inhibit the insulin release. तो यहाँ पे आपको याद रखना है कि beta 2 stimulant, that means beta 2 agonist, they will decrease the body's sugar level. जैसे beta 2 agonist होता है salbutamol, terbinafine, they will decrease the body glucose level because they are a insulin releaser. Okay, beta blockers, they will increase the body glucose level. Why? Because they are blocking the beta receptor, non-selective beta blockers particularly like propranolol, labetalol, etc. So non-selective beta blockers, they will block the beta receptor. They will not only block the beta 1 receptor, they will also block the beta 2 receptor. Now this beta 2 receptor is present on the pancreas. Stimulation of beta 2 receptor increases the insulin release. Blockage of beta 2 receptor will suppress the insulin release. So beta blockers, non-selective beta blockers will increase the blood sugar level, hyperglycemia. They will cause hyperglycemia because of that. And beta 2 agonist will decrease the blood sugar level because they will release the insulin. But now there are certain drugs which can also affect the release of insulin. So drugs like xanthine alkaloids, like xanthine alkaloid sulfonylurea, they stimulate the insulin release, whereas these drugs like thiazide diuretics, diazoxide, then phenytoin, they will inhibit the insulin release. So xanthine sulfonylurea, they will stimulate the insulin release. Thiazides, diazoxide, and phenytoin will inhibit the insulin release. Transport of insulin metabolism of insulin and excretion. Insulin circulates in the free form in the blood. It is degraded by liver, kidney, and skeletal muscle. Now, insulin is metabolized by liver, kidney, and skeletal muscle. So, insulin is secreted from pancreas in the form of monomeric unit. So, whatever normal released insulin is there, that is a monomer. Okay? That is a monomeric form, which is easily diffusible. Now, therapeutically used insulin preparation. Now, whatever insulin preparation you are using for diabetes treatment, so they are available in the tetrameric form. They are available in the tetrameric form. So that's why they are longer acting. They are longer acting because normally insulin क्या होता है कि that is released in the form of monomer और उसकी वजह से क्या है वो easily diffuse होता है easily metabolized होता है ये टेट्रामेरिक फॉर्म जो होता है इंसुलिन जैसे इंसुलिन के मिक्सचर्स आते हैं so they are having delayed action. They are having delayed onset of action. They are having long duration of action because they are a tetrameric in nature. Now insulin receptors. Now how insulin will act? Now insulin will act on its receptor known as an insulin receptor. So insulin receptor they are nothing but it is a type of tyrosine kinase receptor. They are a type of tyrosine kinase receptor. So this insulin receptor is made up of two units, alpha and beta. Okay? So insulin receptor they are made up of two units, alpha and beta. So two alpha units are there and two beta units are there. So these alpha units and beta unit again they are joined together by disulfide bond. These two are joined together by disulfide. Okay? They are connected to each other. Now insulin will bind to alpha subunit of insulin receptor and it will stimulate this binding will stimulate the beta subunit of insulin receptor and which is linked to a protein. Now this protein will be phosphorylated. There will be phosphorylation of protein. Okay? And this phosphorylation will alter the enzyme activity. Enzyme activity means it will alter the different metabolizing enzyme like your glucokinase, okay, glucose 6 phosphatase, kinase, dehydrates, oxidase, etc. So whatever enzyme is responsible for the glycolysis, your Krebs cycle, your pentose phosphate pathway, so that will be altered. Their activity will be changed. Okay, their activity will be increased because okay so this insulin will bind to its receptor particularly alpha subunit then it will activate the binding will activate the beta subunit it will cause protein phosphorylation that protein phosphorylation will change the activity of enzyme responsible for the metabolism of carbohydrate they will increase the activity so this causes the decreased okay this causes the increased the glucose uptake in the cell and decrease the gluconeogenesis. That means glucose will be utilized for energy and there will be decrease in the glucose level in the body. That's how insulin will act. Now you can see over here again. So insulin receptors. So insulin receptors. So this insulin receptor will have, I have told you, will have two subunit alpha and beta. So this insulin will attach to a alpha subunit which is present on the surface of cell and these alpha subunits are linked to a beta subunit which cause the phosphorylation of protein okay after phosphorylation there is a internalization of these proteins this protein internalization of this protein and which causes series of phosphorylation dephosphorylation phosphorylation series of phosphorylation dephosphorylation and there is generation of secondary messenger also for example this phosphatidyl inositol 3 phosphatidyl inositol 3 this phosphatidyl inositol 3 also causes activation or inactivation of enzymes responsible for the metabolism of carbohydrate so यहाँ पे secondary messenger भी generate होगी तो secondary messenger भी क्या करेंगे activation deactivation करेंगे then this phosphorylation जो होता है so after series of phosphorylation cascade so there is a again activity that is known as a kinase activity okay and that will directly affect on the DNA will cause the changes in the DNA will stimulate the transcription okay and will stimulate the protein synthesis of what protein synthesis of protein responsible for the cell growth, that is cellular proliferation and cell differentiation. And this phosphorylation cascade will also increase the transport protein, that is a glucose transport protein GUT, which is again responsible for the increased amount of this kind of protein is responsible for the increase in ग्लूकोज सेलुलर अपटेक कि सेल के अंदर ग्लूकोज जाएगा ज़्यादा, ग्लूकोज का यूटिलाइजेशन होगा, ग्लूकोज का मेटाबॉलिज्म. So that's how that insulin will act. It acts on a specific receptor located on the cell membrane. Practically every cell has an insulin receptor, and these kind of receptor are nothing but the tyrosine kinase receptor. Tyrosine kinase receptor. They are insulin receptor are nothing but the tyrosine kinase linked receptor. It is a glycoprotein receptor consist of two extracellular alpha and two transmembrane beta receptor joined together at disulfide bond. We have seen in the previous image. The binding of insulin to alpha subunit. Alpha subunit is a binding site, while beta subunit have a tyrosine in the protein kinase activity. Tyrosine protein kinase activity. So binding of insulin to a alpha subunit will induce aggregation and internalization of receptor along with the bound insulin molecule. This activates the beta subunit and which is then phosphorylate the tyrosine residue of protein. This series of phosphorylation and cascade of phosphorylation and dephosphorylation occurs which amplifies the signal and result in the stimulation or inhibition of enzyme responsible for the metabolic reaction. The secondary messenger like phosphate and inositol is generated which also have similar kind of action, stimulation or inhibition of metabolic enzyme. Insulin acts via different glucose transporters. Glucose transporters are different glucose transporters. We will see in a different table. Now, absorption, distribution, metabolism, elimination of this insulin. So, insulin is a hormone you cannot give by oral route. So, if you give orally, it will be destructed in the gastric juice and it will be metabolized in the liver. So, orally it is ineffective. So, you have to give by parenteral routes along with the zinc. So, zinc will delay the absorption of this. Okay, zinc will delay the absorption of this insulin and you will get a longer duration. So insulin is absorbed from various kind of routes. For example, you can inject insulin in the using your arms. You can inject in the deltoid muscle, gluteus muscle. Okay, in the thighs also. You can inject in the thighs. You can inject in the buttocks. You can inject in the shoulder muscle. But maximum absorption of this maximum absorption of this insulin is from the subcutaneous layer of your stomach. So maximum absorption is there from stomach area. So insulin is given by subcutaneous route. Remember, so it can be given into different subcutaneous sites. For example, gluteus muscle, thigh muscle, or arm. But it is mostly absorbed from the abdominal wall. So it is the fastest absorption of this insulin is there from abdominal wall and less rapidly absorbed from other sites. Remember. We'll see the next. What are the adverse reaction of insulin? Insulin के adverse reaction क्या? So obviously insulin will decrease the blood sugar level. So it is a dose dependent hypoglycemia. It will cause dose dependent hypoglycemia. फिर ज़्यादा अमाउंट में इंसुलिन लिया तो hypoglycemia है ना. If normal person if you inject insulin to a normal person and if dose is increased, that person may go into the coma and will die because of the hypoglycemic shock. You know that your brain is totally dependent on the glucose for energy, so the person will brain die. Okay, so hypoglycemia can cause death. Dose dependent hypoglycemia, okay, that is the adverse effect. Okay, now because of that hypoglycemia, what happens, your sympathetic system will be stimulated and because of that there will be release of adrenaline will cause vasoconstriction, hunger, tachycardia, palpitation, sweating, etc. So this will be the symptoms. Then again cerebral symptoms will be cerebral symptoms because of the less energy, confusion, depression, coma, and convulsions, epilepsy. Okay, cerebral edema. आपकी जो शरीरों में उसको स्वेलिंग आ जाए. Unrecognized attacks during night, followed by rebound hyperglycemia. So unrecognized attack means what? So sudden decrease in the body glucose level, followed by rebound, sudden increase in the body glucose level. That is nothing but that is known as a Somogy effect. Okay, unrecognized hypoglycemic attack during night, followed by rebound hyperglycemia with glycosuria in the morning. That is known as a Somogy effect. They can be asked question on this. What is Somogy effect? This kind of attack increased or decreased sudden hypoglycemia. It can cause neuronal damage. So neuronal damage is known as neuropathy. Sudden hypoglycemia or sudden attacks of hypoglycemia may cause neuropathy, neuronal damage. Then again, it will increase the retinopathy. Retinopathy will be worsened by repeated hypoglycemic episodes. So this is the main adverse effect. Again, another adverse effect of insulin is there. So insulin lithodystrophy. Lithodystrophy. Okay. So there are of two types. First one is a lipo hypertrophy. So what happens at the site of injection? जहाँ पे आप इंसुलिन का इंजेक्शन देते हो जो साइट है वहाँ पे क्या होगा due to lipogenic property this insulin will increase the lipid level of body and because of the lipogenic property so at the site of injection there is a development of spongy lumps तो वहाँ पे एक छोटा सा गांठ आ जाएगा spongy lumps to lipogenic property, there is a development of spongy lump at the site of injection, and it is known as a lipohypertrophy. Lipohypertrophy. Another effect is there known as a lipodystrophy. Lipoatrophy. Lipoatrophy means loss of fatty tissue of immunological origin. For example, lymph glands. So loss of lymph gland at the site of injection. Loss of lymphatic tissue at the site of injection. That is a lipoatrophy. Then again, visual accommodation disturbances, then neuropathy is associated with the insulin use. Then obesity, edema, and hepatomegaly. These are the adverse effect of insulin. So mostly dose-dependent adverse effect is there, that is hypoglycemia, and it is also known as a type 1 adverse drug reaction. So extension of pharmacological action is known as a type 1 adverse drug reaction, augmentation. We have seen in the very first lecture when we were discussing about the general pharmacology. What are the use of insulin? What are the use of insulin? Uses of insulin. So it is used in the treatment of idiopathic diabetes mellitus, secondary diabetes mellitus, and glycosuria. It is insulin is given in the form of intravenous drip and used to treat the hyperkalemia. Glucose insulin potassium drip has been used in the patient with myocardial infarction. जिसको मायोकार्डियल इन्फेक्शन हुआ है उसमें भी इंसुलिन ग्लूकोज का ड्रिप यूज करते हैं मतलब सलाइन एंड is also used in the complicated arrhythmia due to hypokalemia. So these are the uses. Now different glucose transporters. What are the different glucose transporters? So these transporters will take glucose inside the cell. Okay? So now first GULT1 glucose transporter 1. So it is found in the most of the cells. So it is found in the most of the cells. Okay, what is the function of this? The function that this transporter help in the basal glucose uptake means cellular entry of glucose will be done. Okay. This glucose LT1, GULT1 glucose transporter 1 present in the most of the cells and it will help in the entry of glucose inside. Helps in the basal glucose uptake. Now GULT2 is there. It is present in the liver. Okay, it is present in the liver, beta cells of pancreas, hypothalamus, basolateral membrane of intestine. Okay, GULT2. So again, it is a carrier for glucose and fructose molecule in the liver and intestine. Now GULT3 it is present in the neurons, placenta, testes, and brain. Again, it is responsible for the uptake of glucose in these cells. GULT4 is present in the skeletal and cardiac muscle. So again, responsible for the utilization of glucose in these cells. Activity is increased by insulin. Now GULT5 mucosal surface of small intestine and sperms and kidney. So sperms, sperms और intestine में ये GLT5 transport होता है. So it is also involved in the fructose transport. Remember, the free fructose is only present in the जो sperms होते हैं उसमें free fructose आपको मिलेगा. These are the different glucose transporters. Now, different kind of insulin mixtures. So first one is a conventional insulin preparation, means normal insulin preparation. So conventional insulin preparation मतलब जो normal insulin है उसका. So इसमें भी type है. First one is a lenti insulin. Now it is commercially available. Lenti insulin is commercially available. It is a mixture of crystalline and amorphous insulin plus zinc. So insulin कितना है 3 and zinc कितना है 7. So 30 has to 7, 30 70. Okay, 30 70. So it is a mixture of crystalline insulin plus amorphous insulin to the zinc. Okay, so crystalline insulin is known as a ultra lente, and this amorphous is known as a semi lente. So it is a lente insulin is nothing but the mixture of crystalline crystalline plus amorphous insulin with zinc. Second is nothing but the plain insulin plus natural pH insulin. Okay, it is a mixture. So plain plus natural pH, neutral pH insulin, plain plus neutral pH insulin. So it is a mixture, and you have to make this mixture before injection. Okay, because this mixture is unstable. Okay, plain insulin with neutral pH insulin preparation is unstable, and you must prepare immediately before the injection. It is a highly purified monocomponent insulin. Third conventional insulin preparation is a plain insulin plus PZI. It is known as a protamine zinc insulin. Plain insulin plus protamine zinc insulin. Now again it is a mixture prepared by a patient before injection. Plain insulin is combined with the protamine zinc. Protamine and zinc will alter the kinetics, will prevent the will slow down its absorption. So it will be longer acting. It is also used before injection because these preparations are unstable. Now next point we will see. Next is insulin analog. Now you can see conventional insulin means normal insulin. Normal insulin मतलब क्या? जो आपका बॉडी का इंसुलिन होता है वैसे exactly similar. So that is known as a conventional insulin. Now insulin analog means these insulins they will differ from main insulin in the sequence of amino acid. जो ओरिजिनल इंसुलिन है और ये इंसुलिन एनालॉग जो है इंसुलिन एनालॉग्स so they will have a different sequence, only one or two amino acid sequence will be different. They are not native, they are not native insulin, but they will act on a same receptor, they will act as a same like native insulin. So this insulin differs from the amino acid sequence to that of the human insulin, but they bind on the same insulin receptor and acts like a native insulin. So these are nothing but the first one is a lispro insulin. So it exists as a hexamer. Hexamer form में आता है. It exists as a hexamer and which instantly dissociate into monomer. The duration of action of this lispro is around 4 to 5 hours and is more effective in the reducing the postprandial rise in the glucose, and also hypoglycemic incidence are lower than native insulin. Aspart insulin is there. Again, it is a short acting and it has a similar property to lispro insulin. It is injected subcutaneously before the 5 minutes of commencing meals. खाना खाने से पहले 5 मिनट पहले इसका इंजेक्शन लेना. Insulin preparation is a glargine insulin preparation. Glargine insulin. It is a long-acting analog and duration of action is around 20 to 24 hours. Glargine insulin. Absorption is of this insulin preparation is uniform and not produce insulin peak repeatedly, provides continuous release of insulin, low plasma insulin concentration, and also does not cause hunger due to hypoglycemia between meals. Now long-acting insulin is nothing but these three. These three are long-acting insulin preparation. Remember, इसके ऊपर क्वेश्चन आता ही आता है. Ultra lente DMER and degludec. Ultra lente DMER and degludec, they are known as longer acting insulin preparation. So out of that, remember इसके ऊपर क्वेश्चन ऑलरेडी आ चुका है. So this degludec is the longest acting insulin preparation. So they are already asked question on this. One of the following insulin preparation is the longest acting. So degludec is the longest acting. And remember what are the examples of long acting? Ultra lente, DMER, then degludec. These three are the longer acting. Okay, these three are the longer acting. Out of that, degludec is the longest acting. Okay, you can see over here again in this table types of insulin preparation. First one is the rapid acting insulin preparation. Rapid acting. So what are the rapid acting? These three: insulin, aspart insulin, and glulicin insulin. Glulicin. These are three rapid acting. So one set of action is around 15 to 20 minutes for all. Duration is around 3 to 4 hours. Okay. So out of that, lispro insulin is present as a monomer. Aspart is more rapidly acting insulin preparation. Second one is the short acting. Rapid acting, short acting. Okay. Short acting, in that you have regular crystalline zinc insulin. Okay. And similant. So regular crystalline zinc insulin, 30 to 60 minutes is a onset of action. Duration of action is 5 to 8 hours. It can be given by intravenous route. Now semilente, the onset of action is 1 to 2 hours. Duration is for 8 to 12 hours. Now intermediate acting insulin preparation. So neutral pH insulin or isopen insulin. So duration of action is around 16 to 18 hours. Then lenti insulin, again duration is around 60 to 20 hours. Now long acting insulin preparation. So these four: ultra lente, glargine, DMER, and degludec. These are the long acting insulin preparation. Ultra lente will act for 20-36 hours. Then glargine preparation will act for 15 to 24 hours. And remember, this glargine is only insulin preparation which is supplemented at a pH 4. So rest of the all insulin preparation, they are supplemented at a pH 7.2 to 7.4. That means other insulin preparation, they are supplemented at a neutral pH. Okay, only glargine preparation is supplemented at a pH 4. इसके ऊपर भी क्वेश्चन आता है. Then DMER insulin preparation will act for again for 24 hours. Degludec will act for 24 to 40 hours. It is the longest acting insulin preparation. Remember, इसके ऊपर भी क्वेश्चन आ चुका है. Longest acting degludec. Okay.